Innovative radiology comprises 14 radiologists. Most of us are subspecialized. We've got neuroradiologists, musculoskeletal radiologists, nuclear medicine physicians. My particular interest is oncology. I do a lot of intervention, a lot of biopsies. Innovative radiology covers a couple of hospitals. We run Houston Medical Imaging, our primary medical facility, and then we also read for about 30 sites. In all, our group probably interprets 250,000, 300,000 studies a year. But we're, geographically all over town. We've all got workstations in our homes. We've got workstations in our offices. Yet we've managed to integrate a practice and work together as a group. Over 10 years, you have to realize we developed a practice that was risk-driven. We created workflows based upon the risk, and then the images and the information came to the radiologist. It required a lot of risk coordination. All of a sudden, it's time for meaningful use. Our risk vendor has decided they're not going to move forward with the project, and it's a big vendor, and they're not going to support meaningful use. So we have to find an alternative. What I've done by going with native dictation and the teleradiology platform is I've separated us from the RIS. We no longer care which RIS is being utilized, so they can pursue their own meaningful use for their referring doctors.
Before, we used to depend on RIS. RIS was the one that was distributing the reports. It was distributing, also connecting to images. Now we bypass the RIS, and we give, even if anybody from different offices that would like to communicate with their RIS, we can do that. That's not a problem. We send a message to their RIS, but we give them option totally independent. They don't have to depend on the RIS anymore.
At this point, we're logging into one application, Carestream. All of the information, all of the centers are sending images. They're doing order entry, and once the QC is done and my staff have moved it into a dictation status, we're basically logging in once and seeing our work list. We're able to use workflows to assign certain studies for radiologists so that they'll open up automatically in our queue. I would have to say that the voice recognition, the engine is markedly superior. I mean, I think we're much happier with the performance, with the accuracy, with the speed, and having a faster learning curve. We can now drop images. We can drop structured reports. We can look at lesion management, for example, and drop that into our reports. So all of a sudden, our reports are gaining a little bit extra dimensionality. Images, graphs, percentage change over time. And then lastly, we've got this ability to distribute these images to the referring doctors.
We don't want to change anything on their end. They can use their patient ID, they can use their session number. So they send us the study, we work with it. We create the rules that assign that study to that same office or referring physician that send it back to us. So once our radiologist read the study and it has the final report, we are able to send that study exactly where it came from without interruption for anything else. To add on the new site, it's just a few minutes. Like you talk on the phone with the referring physician, they will start sending the patient, they send you the patient, you create the order, you show them, it takes minutes. It's no more like hours like it used to be.
When I'm able to the radiology, is able to send an email as soon to the referring physician. He's checking his iPhone. As soon that the procedure and the reports are ready, and the referring physician receives an email, that is power. That is power.
It's very intuitive the way the Carestream has been set up. The portal over the web is extremely intuitive. Some of the other software packs that we get on CDs are less than intuitive, and it takes a while to figure it out. So we're happy with the fact that it's intuitive and it's very fast.
And when I can see the images myself and I can show the patients those images and talk about those, it's good for the patient, it's good for me.
For me as a clinician, I got a bunch of patients waiting. I got to be as efficient as possible. So I'd much rather have a portal that's very quick and responsive so I can view the images in a very quickly and time-efficient manner rather than having to load up CDs and try to scroll through images at a much slower pace. And we've now gotten to teleradiology to be able to look at images quicker and more efficiently in order to minimize patient waiting.
The value of teleradiology to our practice at Oncology Consultants is that we have all of the images and the reports. As soon as it's dictated, it's immediately available to the referring physician. So we have physicians that pull it up on their pad or on their telephone. They can do it from home, they can do it from work.
You know, teleradiology has a little bit of a bad rap. And the reason it has a bad rap is you have centers sending images out to faceless radiologists elsewhere. You end up with a transaction of images being sent one way, and you have a piece of paper, a document, or even if it's an electronic document, sending back. So the referring physician doesn't have a sense of the quality of the radiologist, doesn't have a sense of the, the quality of the interpretation, and was the study even adequate? This teleradiology model is excellent because all of a sudden the referring physician and the patient, the end users, they're going to be able to look at those images. There's something comforting, I think, to a referring physician when he can pull up the study. Even if he doesn't interpret it, he can just gauge the quality of the study. He can see the content of the report, and he can have a sense of satisfaction that this is a good product, and he can believe in it, and he can make decisions, clinical decisions, to take care of his patients more comfortably and at ease. And when you get to engage with the doctor and actually talk about a study and share an image, I mean, you develop a relationship that might not have been there before. That's the fun part of medicine. I mean, medicine is relationship based. And because the referring doctors now have direct access to view motion, we're finding that they're adapting it and they're enjoying it and they're utilizing it with a much higher degree of both interest, enthusiasm, and just the number of people that want to use it. And ultimately, that's what's going to help us as a group. We're going to get more centers to read. We're going to have more patients referred to Houston Medical Imaging, and we're going to get busier.